Hello and welcome to the Know and Do Better podcast. My name is Dr. Melanie Carminati, and I am looking forward to chatting with you all about this very important topic, osteoporosis. So this has been coming up a lot in some of the Pilates wellness classes and one-on-ones that we have at Inspira at our main office in Park Slope. And I have a handful of patients. I know the general public, movement practitioners, just average Joes, everyone is a little bit confused or just not informed about osteoporosis in general, about safe movement for osteoporosis, and then also about movements that should be avoided. So why don't we start from the very beginning? Osteoporosis. So in terms of the pathology for this diagnosis, there is involvement of different bone cells. There's two different kinds of bone cells, osteoclast cells and osteoblast cells. So the osteoclast cells are the bone cells that break down bone tissue and take away old damaged bone tissue and debris. And then the osteoblast cells are the builder cells that bring all the nutrients that the bones need to build. Osteoporosis itself is a metabolic disease with both endocrine and physiologic influence. Those two things to always keep in mind. There are two types of osteoporosis. So the most well-known type of osteoporosis is type 1. This is post-menopausal, and it is influenced by the decrease in estrogen production. So this is why people tend to associate osteoporosis with older females. However, that is just one type of osteoporosis. There's actually a second type of osteoporosis and even a third type. Type 2 is after age 75, and it's seen in both females and males. The ratio of that is 2-1, so it still is more prevalent in women, but it is possible for men to have osteoporosis. Now, the final type is secondary osteoporosis. This results from predisposing medical conditions, such as Crohn's disease, eating disorders, prednisone use, and being on different types of chemotherapy. I remember when I was working at Polestar Physical Therapy and Pilates Center in Miami, in the Coral Gables office, there was a patient who was receiving care and was recovering from eating disorder and actually had osteoporosis. She was fairly young. I've also had other patients who had Crohn's disease, and because Crohn's disease involves malabsorption of nutrients, they then develop secondary osteoporosis. So osteoporosis, as I mentioned before, is endocrine and physiologic. So it's always important to consider that. If nutrition is affected, if gastrointestinal conditions are at play, bone health should be a consideration. Now, there are some associated risk factors and conditions. Some are modifiable, some are non-modifiable. So the non-modifiable risk factors are age, if you're older than 50, right? So we can't change our age. If you are Caucasian or Asian, if you have Northern European descent, if you have experienced menopause, if there's a family history, if there has been long periods of inactivity or immobilization. So this is people who are on bed rest, people who have spinal cord injuries. And then there are modifiable risk factors. Modifiable risk factors, what can you modify right now? Nothing in the past, right, can be changed. But right now you can modify your physical inactivity. You can become active. You can modify if you are taking in tobacco, taking in alcohol, modify what medications you're taking, and then modify your diet and nutrition. Some clinical manifestations of osteoporosis are loss of height, postural changes. But before I get into that, I just want to say that osteoporosis is unique because it's not like you wake up one morning and say, wow, I really feel like I have osteoporosis. It's not like any kind of pain syndrome. It's unique in that the clinical manifestations are not typical for most diagnoses. So I mentioned loss of height, then the postural changes. The postural changes that we see are lax abdominal musculature, protuberant abdomen, forward head posturing, the increased thoracic kyphosis, dowager's hump, a loss of the lumbar lordosis. Secondarily, you can experience back pain because of all of those postural physiological changes. And then one of the more well-known risk factors for osteoporosis is fracture risk. So you can have fractures in the hips, in the ribs, in the radius or your wrist, ulna, and your femur. Now, before you have osteoporosis, commonly what happens first is you have osteopenia, which is when there's too little bone and low bone mass. But osteoporosis is defined as decreased bone density. Now, when I started off the talk a few minutes ago, I mentioned the bone cells, osteoclasts and osteoblasts. And just as a reminder, the osteoclasts break down existing bone and the osteoblasts lay down new bone for mineralization. When I was in grad school, I was amazed to learn that bone is dynamic tissue. It's constantly undergoing this bone remodeling cycle. Old bones being broken down, new bones being laid down, and there's this ongoing cycle of breakdown and buildup. The purpose of this bone remodeling is to maintain equilibrium of strength and integrity of the skeleton by replacing old damaged bone with new bone so that it can act as a source of vital minerals that we need, such as calcium. Calcium is needed for regulation of the heart rate, muscle contractions, blood pressure, and other systemic functions. So I just went into the pathology. Now, what can we do with this information? How can we apply it into our physical lives? Well, let me tell you, there is a physics law known as Wolff's Law. Wolff's Law states that bone is laid down in areas of high stress and reabsorbed in areas of low stress. I'm going to repeat that one more time. Bone is laid down in areas of high stress and reabsorbed in areas of low stress. So the bone alters its shape, strength, and density in response to external forces. External forces cause osteoblast activity to outweigh the osteoclast activity and therefore increase bone mass. That means that with more physical activity, you will see more bone being laid down. This is amazing. This is why doctors say, oh, you have osteoporosis, you should exercise. It really isn't that general, but with weight-bearing activities such as walking, running, elliptical, anything where your bones are being bared weight through, this is weight-bearing activity. This will stimulate the bone builder cells, your osteoblast cells. This is what we want for prevention and then management of osteoporosis. Now, when you do have osteoporosis, this leads to increased fracture risk, which we did mention. So for the National Osteoporosis Foundation, they have 4 recommendations for management and prevention of osteopenia and osteoporosis. We mentioned weight bearing, so the first thing that they recommend is a daily walking program. They want it to be rigorous, at least 30 minutes, moderate intensity. The second is to have resistance training in your exercise program. This can be springs, bands, weights. The third is extension-based exercise and overall core strengthening. But why extension-based? The spinal movement of extension is when you're going into a back bend. If you're in Pilates, think of proud Pilates chest or think of swan, all of the swan variations where you're going into that spinal extension. This is what we want to promote for osteoporosis management and prevention. The extension is going to help correct and prevent the development of the thoracic kyphosis and dowager's hump. And then the fourth, very important, is balance training. Balance training, number 1 is weight bearing, but number 2 is helping to stimulate your proprioceptive fibers so that your balance is optimized, because falls are directly correlated to osteoporosis-related fractures. Okay, so now you know Wolff's Law, you know the 4 recommendations from the National Osteoporosis Foundation. What movements should be avoided? What we call movement contraindications. There are 3 contraindications for movement. The first one is flexion, especially repetitive flexion like crunches. The second is end range side bending. The third is end range rotation. And then any combination of those 3 motions should be avoided. Now I'm going to add some caveats because I know I have many Pilates aficionados in my practice who are coming either for PT or Pilates. If you have worked one-on-one with a skilled, licensed healthcare professional, physical therapist, or with a rehab-oriented movement practitioner who has a trained eye, who's seniored, who's more master level, and you have worked through lengthening of the spine while you're going into flexion, or you're able to articulate, it's likely that you will be okay. It depends on each individual. If you're already in a state of fixed thoracic kyphosis, it's not going to be safe for you to do the flexion. But for most people, and like the people that I had mentioned, with guided and a skilled eye, they will be able to do some flexion. So what's safe? What is safe no matter what for anyone with osteoporosis? There's some safe Pilates mat exercises, neutral spine exercises. We already mentioned spinal extension. Definitely want to do that. Quadruped, amazing for weight bearing through the extremities. The Pilates exercises that you want to be cautious with are anything that's multi-planar, multi-joint movements, because that might get the spine into a flexed, rotated, and side bent position. And in terms of areas where osteoporosis is found, because this is important too, contraindications that I mentioned were for spinal osteoporosis. You can also have osteoporosis in your wrists and your femoral neck. That's because the bone makeup and the bony matrix for those regions is different than the rest of the body, but it can be present in the spine, the wrist, or the hip, sometimes a combination of two of those or all of those. But the spinal contraindications that I mentioned, the movement contraindications, were for spinal osteoporosis. If you have osteoporosis in your wrist, what you want to be avoiding is punching, boxing, high impact. And then if you have osteoporosis in the femoral neck, most compromising position is something like pigeon pose because of the pressure that it puts through the femoral neck. We just had a rundown of the pathology of osteoporosis. We talked about movement contraindications. We talked about the different types of areas where osteoporosis can be present. I hope this information was beneficial for you and that you learned something about osteoporosis. If you have any questions, don't hesitate to reach out. I will gladly expand further if there are any questions. Thank you all for listening.